All right, well, welcome everyone. I think we'll get started here. Welcome to Grand Rounds this morning. It's my pleasure to introduce Dr. Nathan Every to be presenting at Grand Rounds this morning. Dr. Every is a former associate professor of medicine at the University of Washington, and he is currently a partner at Frazier Healthcare Partners, which is a healthcare investment firm. Dr. Every did his undergraduate training at the University of Pennsylvania before going on to medical school at Emory University. He then came out here to the University of Washington to complete both his residency in internal medicine as well as his fellowship in cardiology at the University of Washington. In the middle, he completed a year as chief resident at Swedish Hospital when our chief residents were also at Swedish. After fellowship, he completed a health services research fellowship at the Seattle VA. And after completion of all of this training, he stayed on as faculty at the University of Washington in the Division of Cardiology. He then went on to be director of the Cardiovascular Outcomes Research Center at the University of Washington. He's performed multiple studies evaluating the costs and outcomes of new procedures and pharmaceutical agents. A major focus of his research has been on how processes of care for patients with myocardial infarction affect clinical outcomes and cost effectiveness. His research has resulted in multiple publications in high-impact journals such as the New England Journal of Medicine, JAMA, and The Lancet. Now Dr. Every is a partner at Frazier Healthcare Partners, and he is a member of the growth buyout team specializing in middle market healthcare companies. So today, Dr. Every will be presenting transformation of fee-for-service to value-based medicine and the role of physician leaders in the next generation of care. So please join me in welcoming Dr. Every.
Good morning. Thanks very much. I'm going to put a timer on so we can keep on time here. Thanks for inviting me. I'm really happy to be back here. It's been a lot of years since I spoke in front of this group, and listening to that introduction, I did a lot of training here. So my first joke of the day, we're going to keep this very light, but I just made this one up. This is the hardest work I've ever done getting ready for this talk that had no profit motive in the last decade. There was no profit motive here. And really my only motive, biggest motive, and I sort of wished I knew this when I was sort of a younger doc, was just seeing some of the things that are going on outside of the world. And I have a thesis that the next decade or two around care, value-based care, re-engineering care is going to be, it has to be physician-led. And so I'm really going to talk about sort of why I feel that way. And I hope if I can inspire one or two or four of you to really think outside of the box that we live in to be one of those physician leaders, that's really one of my goals. So with that, I'm going to get to work here. And with my first slide about what I've been thinking about to get ready for this talk. For those of you watching CNBC this morning on the treadmill like me, healthcare reform is actually back on the table. Ryan is out there talking again. It's a really, really interesting time. We thought fee-for-service was largely dead, at least on the investment side. It probably is. We can get into that a bit, but the next decade is going to be really interesting. And as I said, I think it's a new era for physician leadership. The issues are, and we'll go through them, and there's not any surprise to anybody in the room, cost and quality. We'll talk about it a bit, but I don't need to convince you that those are the issues. And what's interesting is everything we've been doing and things that I was thinking about 2 decades ago and that actually have been in practice now for a decade really have had somewhat marginal impact. And I think we're going to have to do something bolder. Now, I'm going to stay within the bright lines of what we can do. We could have a one-payer system. I'm not going to talk about that. I actually think it would be quite effective, but I don't think that's realistic. But these are some of the issues we're going to talk about. We're going to talk about the response. We're going to talk about what physicians have done to lead these organizations. This is an interesting one, the bottom bullet here. I'm told I'm supposed to use the pointer. There it goes. Whether this is a corporate initiative or entrepreneurial. And you know, this jargon may or may not make sense to folks, but what I'm going to talk about in some of these case studies I'm going to talk about are entrepreneurial-led. They're led by an individual or team of individuals that have done pretty risky things to change healthcare delivery, change the world, to make money. Or is it a corporate-led initiative? Is it Providence? Is it HCA? Is it you know, one of the big blues? And I have a bias in that, but we're going to talk about that. I'm not going to get deep into this, but actually it's pretty darn important to think about what, if you're going to be a physician leader, and we really need tons of physician leaders. Some of them are medical directors. Some are, you know, vice presidents of medical centers. Some are chief medical officers. So what is that right training? You know, I literally get calls, I would say once a week, twice a week, 3 times a week, MD MBAs. Some people have never practiced. Some people have practiced and gone back and got their MBA. You know, I'm not sure the right answer to that, but I think training is a really important thing, and I'm going to argue, and I think it's really important, it's leadership, not how to read a spreadsheet. And we're going to talk about that a bit. Okay, so physician business leadership over the last few decades, and I've got a few pictures, and I'm going to, you know, make my jokes. Please laugh. So the first one, you know, the first physician leaders were running practices. These were guys that were running practices, so that's this guy. And you guys all know about these folks. They're practice leaders, and really what they're mostly interested in is volume and, you know, getting the most payment and being the most profitable within their entity. And second joke, you know, this is, and again, what we all grew up with is people being indicted for various Medicare fraud, et cetera. I frankly think we're going to leave that all behind because obviously that's not what I'm talking about. The next one is physician executives, the Paul Ramseys of the world, physicians that are running complex organizations. Sometimes they're people-led, provider-led, sometimes they're people and buildings, hospitals. Sometimes they're insurers. And then the last one are physician entrepreneurs. We're going to talk about some physician entrepreneurs. You know, what does entrepreneurship mean? To me, it's somebody that's taking a good amount of risk. We're going to talk about that. So a little bit, you know, I guess I was thinking about my own view. So this is not me, but it's a picture I found on Google. So when I was training and when I was in medical school, and maybe this is true, I don't know if it's true, I don't know if it's false, but the notion of physicians and money, physicians and dollars, physicians and profits, was sort of, I didn't want to think about it. I thought anybody that thought about it was, you know, unethical or whatever. And, you know, I had a pretty bright line. If you're in it to make money, you're in the wrong business. And frankly, as a provider, that's probably a very reasonable place to be. It's not exactly what I'm talking about today when I'm thinking about physician leadership. I was a health services researcher for a good long time, and I still think in that way. I don't have a picture of that. I couldn't find a good one. In that case, we studied narrow interventions. And I really look back on that work, you know, what changes physician behavior? What works? What doesn't work? How do we improve quality? And, you know, look, we can talk about it in the discussion. Perhaps one of the reasons I left that world was I wasn't sure that we were really moving the needle. And frankly, I was sure certain interventions were going to work. And they kind of didn't. Like I thought, well, if you pop up a reminder and tell people to screen or give a flu vaccine, everyone's going to get. Our interventions were pretty weak, and I think some people in the room know that. So anyway, innovators' view. You know, I was in the technology business. I thought about this as a technology-based solution, and we'll talk about that. And today, I really for the last 17 years, I've been a flat-out investor. And you know, we think about things differently, but in healthcare services and healthcare delivery and healthcare investing, we absolutely have to move the needle on cost and quality or we can't make a profit. So that's been my own personal journey. This is medical inflation, the Milliman Medical Index. You guys probably see this every month. I was going to say every quarter. You don't think in quarters. These are actually staggering numbers. Let's take it. So this is a cost per year per insured person. It's $25,000 in 2016. It was $8,400 in 2001. And the employee side of that is $11,000. And frankly, actually, when I think about the last time I spoke here, which was 7, 8, 9 years ago, it was sort of the same slide. It was just back 7, 8, 9 years ago. We've bent it a little bit, and I'll show you some data. We've bent the cost curve a little bit. I think we've done the easy things. You guys all know it's unsustainable. So, are Ryan and the Republicans going to fix this? Are the big IDNs going to fix this? Is Boeing going to fix this? Let's think about that for a second. So the premium increase, these are jumbo employers. Okay, this is Boeing, this is Microsoft. We're running at about 4%, 2-3 times the rate of inflation. Frankly, you can see we've tamed these a bit, right? 15% in 2002. This is actually somewhat promising, and Medicare is even a bit better. The challenge is, as I think about it, is I think we've picked the low-hanging fruit. And what we've really done when we think about premium increases, we've cost shifted to the employees. I'm sure everybody, I don't know about residents, you guys have big copays and all that? No? No, we do. In general, employed folks, our insurance plan at my investment firm is a $8,000 deductible and a 20% copay. And that's what the corporate world is out there. So these reductions in premiums have really been on the backs of folks that are paying much higher premiums. It's an issue, and I think we've kind of going to run out of steam. I mean, how much copay are people going to do? Institute of Medicine report, you guys all know this. Healthcare is 18% of GDP. $750 billion in waste. Frankly, we haven't gotten after much of it. We're going to talk about it. Let's think about where the waste is. And one man's waste is another man's, life-saving technology. But what we've gotten after is length of stay. We've gotten after appropriateness. We've gotten after, we call it post-acute care. Nursing home use is way down. Rehab use is way down. LTAC use is way down. Again, low-hanging fruit for the waste. I think we haven't got our arms, and I know this is true, that I think physician-led organizations are going to get after the waste much better than business-led organizations. And we've really been doing it for decades on businessman-led organizations and really haven't moved the needle. All we've done is cost shift. I'm not going to kind of here today to preach that I actually know what we as physicians can do. I just think in our hearts and in our training, and for those of us who take care of patients, can make these trade-off decisions much better than the business folks. And in the last 2 decades, the physician leadership has been placed in a box where we're medical directors and we're guys sort of doing utilization review. That's not at all what I'm talking about. I'm talking about leadership. I'm talking about very senior positions or owners or founders of these businesses. We'll talk about them. This is my slide on changing physician behavior. Another thing I've been thinking about as I was getting ready for this presentation, I'm just going to keep an eye on my watch here so I do this properly. It's in my world, during research and post, I've been surprised generally on how weak and how poor we've been in changing physician behavior. I think you guys all know this stuff, but in a general sense, and you guys will correct me if I'm wrong in the discussion, but in a general sense, weak passive interventions, pop-ups, mailings, careful, trying to convince docs to change their ways has been largely ineffective. My bias was dollars matter, that when you incent physicians on a dollar basis, there have been some studies that dollars do change physician behavior, although that's actually been relatively weak, all things considered. Academic detailing, doctor to doctor, has worked. Some audit and feedback. My vaccination rate is 73%, the rest of the practice 93%. It's worked some. It's all been actually decently weak. And again, these are top-down administrative changes, in my view, that really haven't moved the needle in a big way. Arguably, can our IT systems get better? Can artificial intelligence help? I'm actually modestly skeptical that we're really going to move the needle in some of these interventions. So physician leadership, and this is the gist of what I'm getting at here. I don't know if everyone's a doc in the room, but let's assume most of us have some serious advantages. The medical knowledge and the trade-off is an unlearnable skill. I mean, this is something that we've done forever. It comes in our heart. It comes from taking care of patients. Frankly, it makes me a little skeptical of MD MBAs who haven't practiced, who have only done residencies, et cetera. So we've got medical knowledge. Some of us have leadership skills. I don't know if I do, I don't know if you do, but some docs really do. And that actually is the gist of what I'm getting at, because some of these organizations, physician-led, that have been very successful, have leaders that are convince other doctors to follow them. And that is probably the secret sauce. The business skills is an interesting one. You got to have some basic skills, there's no doubt about it. Businesses today, and certainly this is what we're involved in, are metric-led, data-driven businesses. You have to be able to understand the financial statements and metrics that can move organizations. Does that mean you need to go back to school? Perhaps, but you certainly need to be trained up in them. And physicians that don't have that skills are at a disadvantage. So we got to figure out, I learned them through my work. I didn't go get an MBA, but that is one way to do it. So the phenotypes are the founder leaders. We're going to talk about some of those. The executive vice president of healthcare systems, that's the Paul Ramseys of the world. The chief medical officers tend to be more, as a medical director, on the medical side. Really is sort of narrow. And my argument is that we need to sort of break out of that box and get more on the business side. Our advantage is peer engagement. There's just no doubt about it. A physician-led organization is going to have, in my opinion, have a better impact. A little thing in the bottom, which I found, hospitals with physician CEOs achieve 33% higher quality scores. And I think my gut is, I think you probably agree that there's some merit to that. How do we train and encourage? Today's day one. Let's start thinking about that. This is another thing that I was thinking about as I got ready here, is what business segment is the best fit? Who's going to make this change? Okay, so IDN, Integrated Delivery Network, is the Providence system with doctors, bricks and mortar, and a payer insurance plan. This is a little bit of the flavor of the day. I got to control everything, Kaiser, and then I can move the needle. Truth is, actually, they haven't moved the needle all that much. Kaiser costs are pretty in line with the rest of us. They invest higher, they pay their docs better, but they are not bending the cost curve better than the rest of the world. So, I have a little bit of bias that maybe IDNs aren't the answer. Payers, the blues. Could you go and run the blues and change the world? I have a gut feeling that payers are going to become more and more irrelevant. I don't think that's the way you come at it. Payers really are utilization managers, and that's not what I'm talking about. I have a little bit of a bias that if you start with a provider group, and those are the examples I'm going to give, provider-based leadership is perhaps where we can really move the needle in value, which is cost and outcome. Because as providers, we're making all the orders, we're making the choices, and I think we can contract out a bed. I think we can negotiate with payers. My gut is I like provider-led organizations as a way to start here. And I'll talk about physician entrepreneurs. Okay, so a little bit of additional background here on sort of what we know about cost and quality control. So, everybody's got their jargon, the flavor of the day 5 years ago, 7 years ago, 9 years, we're going to push it to the consumers, okay? We're going to let them make choices. We're going to give them information. We're going to get skin in the game. It's not been that successful. We haven't bent the cost curve, and I'll show you some data about what employers think. Again, as we shift risk to the patients, and we say, look, here's your $10,000 for outpatient. You decide whether you want to pay $300 or $800 for a CAT scan. It's actually not working particularly well. Again, skin in the game will make you more responsible. For some Americans, that's true. For other Americans, it's not. And we'll go down a bunch. So let me see if my fourth joke is here. There it is. Okay. All right. So that was one picture, right? And you could say, well, what's that mean? And then I got another picture. So I won't put my political stripes, so you can choose your picture. But, you know, the rhetoric of we've got to make insurance cheaper, to me, is beyond ridiculous, right? Because it's just a cost shift. So, yeah, I can make insurance a lot cheaper for a 25-year-old, and I could make insurance a lot expensive for a 62-year-old with breast cancer. This is an incredibly silly argument to me. And we cannot make insurance cheaper. We've got to bend cost, and we've got to improve outcomes. Making insurance cheaper is just shifting things around. So if we uninsure more people, they're going to show up at the ERs, we'll pay for it in another way. If we insure a lot more 20-odd-year-olds, it's going to get much more expensive, likely. So I don't think I need to convince folks in the room that making insurance cheaper is literally an impossible situation unless we bend the cost curve. And then there's things that people throw out, you know, get rid of the state lines. I think that's rhetoric. I don't think that that's a big one. Remove the frills. You know, we don't need maternity care for men, and then our insurance is going to get cheaper. Look, this is a population-based insurance question. So again, it's pretty silly. Again, actuarial values bands of the plans and changing age bands. Again, if you're covering less, your insurance payments are going to be cheaper. So if you exclude chemotherapy from a previous cancer patient, then yes, the insurance is going to be cheaper. Somehow, someone's going to have to pay for the cancer recurrence. So as a society, you know, we don't have to get way into this. It's really not the point of my discussion. But, you know, I guess the point is that the rhetoric around how to make insurance cheaper, to me, is intellectually incredibly dishonest and really won't work. And it gets back to systematic changes on how to bend the cost curve if we can. This is something that I, pointed out, but it's pretty interesting, and we've seen it. But so the worker contributions in the blue, I mean, this is a pretty incredible number, right? 99, it's 1,500, it's 5,000 this year for an $18,000, employee. But we can see substantial increases both by the employer and the employee. And man, if you're, a $82,000 a year tech worker, I mean, these are really big numbers. And so I think we are out of room here with cost sharing. Kind of interesting slide. Okay, so employers, what do most employers think about current cost initiatives? Now, this is 2016 data, it's survey data, and it sort of brings up the point of what we're doing is not really working. And this is pretty important. I mean, if you're asking Microsoft and Boeing what works, okay, so 41% think extremely well or very well to contain costs is wellness and prevention. So that's the best. At the bottom is the consumer-directed health plans, meaning we're going to control where we get our CAT scans. I mean, these are pretty sobering numbers. The best is 40%. I mean, what it argues is most of the stuff we're doing around the edges is probably not working. These are all pretty modest changes. But again, aggressive management, especially pharmaceuticals, that's coming out a lot. More negotiation, improved management of behavioral mental health. These are all largely around the edges. Okay, so let's get into risk bearing a little bit. So the notion, okay, so let me sort of set the stage here. So light gray is 14, and then dark gray is 2016. So these are hospitals, and we're asking them clinical integration with contracting with payers. So hospital risk management strategy, no plans to take risk beyond modest savings. And so no plans went from 40% to 30%. So at least 70% of our hospitals are thinking about risk. 28% are experimenting risk, but not taking a big one. Look at this one. Committing to move the majority of revenues to full risk within 5 years is 6% and actually sort of trending down. We're going to talk about the risk-bearing sort of strategies, which are bundles and things like population-based health ACOs. And again, I don't know how many in the room 5, 7, 8 years ago thought that was the answer. It doesn't seem to exactly be the answer, but we'll talk about that. Certainly, people that are living it and looking at the P&Ls of these organizations thinking that risk may not be the answer for them. Direct contracting with employers, University of Washington with Boeing as an example. 53% of employers would consider, and we can ignore all these, 53% of employers would consider direct contracting with hospitals and providers. That's kind of interesting to me. And then basically getting the insurance people out of the middle of managing the care. So bundled payments. I hate to do the hand thing, but let me just ask, who knows what bundled payments are, just so I have a good sense? And I don't know if it's sort of hit your radar screen in an academic medical center, but bundled payments are pretty interesting to me. And again, most of you know what this is. It's a single payment for an episode of care. Easiest way to think about it is, to me, is a hip replacement. You get a single payment for all the care that's provided up to 30 days, 60 days, 90 days. The big thing there is really post-acute care. So you're thinking about who are the patients I'm operating on? How long are they going to be in the hospital? Where are they going to be discharged to? And most of them are 90 days hospitalization, 90 days discharged. The BPCI, it comes in a lot of flavors, but two of them here is the joint replacement. This is kind of interesting. So the joint replacement in 67 markets, the bundle is mandatory. Now at the bottom here, I have Trump price effect because I'm not 100% sure what's going to happen here. I think the law of the land at the moment is that is in place. So if you're in this market and you're replacing hips, you're in a bundle. Price, who's an orthopedic surgeon, has said he doesn't love bundles and he wants it to be voluntary. So I don't know if this is going to be rolled back. But in 67 MSAs, and by the way, they're in the highest cost MSAs, the bundle for lower extremity replacement is in place. And generally speaking, there's a sort of a shared savings model. Obviously, if we save $10, you get 5, I get 5. But there's increase in downside risk. Generally speaking, people aren't taking a lot of downside risk in these bundles today, meaning, you know, the bundle is $10,000, I spend 11, you know, am I on the hook for half of that? And so it's a bit of an evolving strategy, but I have to say, and I'll show you some data, and I'll show you some data from one of our companies. The bundle is pretty effective, and I'll show you why, in joint replacement. Listen, I don't think it's going to be effective in heart failure, but I think it's interesting. In oncology, in a bit of a distinction, it's a voluntary program. It's 6 months after the start of chemotherapy, and it's upside only for first 2 years, meaning you get $17,000 to take care of a breast cancer patient. If you spend 15, then I take half or a quarter or whatever the deal is. So it's upside only. It's kind of interesting, you know, a lot of people are going to sign up for that. If you're going to take real risk on the downside, people are less. And again, my last bullet on Trump price, I don't know where this is going. Now, this is kind of interesting. No matter what happens with healthcare reform, Trump and Price, and the federal government, from a private payer perspective, the Blues, the commercial plans, Aetna, United, I definitively know by talking to those organizations, they believe the horse has left the barn on value. That they think that it's the lay of the land and the way of the land that we are going to value-based care, whether it's bundles, whether it's ACOs. We're not going back to a fee-for-service world. That's what the commercial world thinks. I don't know what Price Trump are going to do around this, but again, they only control some of the spend. They control the Medicare fee-for-service spend. Remember, 1/3 of Medicare patients are on managed Medicare Advantage plans, which are commercial plans. And again, those folks within a set of rules can do what they want. So I think bundles and value are definitively going to stay with us. And I think, again, it comes back to doctors controlling those bundles and value care. So back to my academic days, I just want to point out that I put the what's that called? Footnote. You like that? I typed that in myself. You should have seen me like looking through the academic research, and it was really quite interesting. I didn't even know how to read this stuff anymore. And I didn't put p-values in here because I thought it was disingenuous, to tell you the truth. So this is from JAMA. It was recently. This is lower joint reconstruction. This is the bundle payment project. Here's a little bit of data I thought was interesting. I didn't make this chart really well. I did it myself. So there's two comparisons here, all right? This group here is bundled hospitals, and these are matched non-bundled hospitals. And this was actually a real decent way to do the study because, look, if we're in these hospitals, perhaps the bundle's moving the needle. In these hospitals, there's no bundle, okay? So here's the dollars spent on total joint recon on bundled hospitals. They spent about $30,000. When the bundle went into place, they spent about $27,000. When there's no bundle, you know, and the math here is a little funky, but the difference was about $1,166. Actually, it's kind of modest in my opinion, and a pretty decent without the bundle. It was going down anyway. So I thought that was kind of interesting. Discharge to post-acute care, pretty big needle mover there, right? 64 to 53%. Without the bundle, it moved as well. These are statistically significant. I don't know if they're, you know, economically or clinically significant. Length of stay was really modest. I'm a believer in bundles, and particularly in simple bundles like joint recon, but I found this data sobering, and you'll see from one of our companies it's better. 90-day mortality, you know, I didn't put a p-value in because it's hard to imagine that this is really different. I think readmit, it was also non-significant. You know, there's a trend to lower readmissions. But I think the general view on bundles is that they're modestly cost savings and they don't seem to have a detrimental effect on quality. And I think bundles work, you know, and again, chemo, I think in orthopedics it makes all the sense in the world. There's other things that it makes less sense to me, but bundles are interesting. We'll talk about some pluses and minuses. Okay, population-based payments, really different, all right? These are all the ACOs. So PMPM, per member per month. We're going to give you this money, you're going to manage the patient. There's a lot of risk adjustment here. There's a lot of gaming of risk adjustment. We all know that a elderly, multi-comorbid, dual-eligible Medicaid, Medicare patient, you know, it's a much more expensive patient to take care of. So there's good work being done in risk adjustment. And this leads to one of the population-based payments methods are ACOs, accountable care organizations. You guys know that. There's some data out there that these ACOs saved $400 million in 2014. It's actually a pretty modest number, but it's a number that's thrown around. Again, shared savings with different downside penalties, et cetera. And there's real tension with fee-for-service models. Because if you're Providence and you're wanting to keep your beds filled, the ACO you're going to keep them out of the hospitals. So it's a tricky problem. Going to pick up my pace here. This is from JAMA. This was the Pioneer ACO data. You guys have probably seen it. Is it coming? You know, it's a little blurry, but there were some savings. In year one, $36 per member per month. That's pretty real when you're talking about millions of people. But the reductions reduced, and that's the orange one, in the second year. First year, second year, first year, second year. Most of that reduction is lower inpatient utilization, okay? There was some improvements in timely care, but these are all of the 18 ACOs that were studied. All of these really didn't have much of an effect. And again, they showed markets. You know, California is a mature sort of management market, and they seem to have better luck there than in the middle of America. So tension between bundles on one side and pop health accountable care on the other. And frankly, all our hospitals are doing both right now, or many of them are, so it's kind of tricky. Key components of making this work is actually pretty important. I really have gotten religion on data. Again, I was a health service researcher. The amount of time and money and effort to get the right data, it's a huge, huge effort. It's completely required. And these entrepreneurial efforts that we're going to talk about are on the backs of spending millions and millions of dollars of fantastic data systems. You can't do it without data systems, and it is incredibly expensive. I honestly don't know why it's so expensive, but it's expensive. Stakeholder alignment's a huge one. You want the doctors and the hospitals and the nurses and the discharge planners and the nursing home and the pharmacy all aligned. It's hard work. Care redesign is sort of the same thing. So, the physician and economic leadership, we're going to get a little bit to my thesis. I'm going to raise my hand and tell you I'm not fully sure that I'm right, but I'm going to throw it out there anyway. And we're going to talk about the physician entrepreneur. Classically, I put fee-for-service churn. The physician entrepreneur was a person that maximized profit, that maximized revenue. We are definitively moving away from those days. And the models that I'm going to show you, some of them started in fee-for-service, but they ended up in value. And we're going to talk about outsourced providers. You guys may know about that. And we're going to talk about value creation. That's my world. How do you create value, enterprise value, equity value through efficiency? IT spend is critical, through scale and through contracting. All right, so these are examples. One of them I actually have an investment in, but these are all private, largely private companies, so it doesn't matter to me. So this guy here is a friend of mine. He's Lynn Massingale. He started a company called Team Health. Well, Team Health is now a giant company. So he's an ER doc, and he started back in the 90s, basically outsourcing the emergency room. Is that a good idea or bad idea? I don't know, but we'll talk about it a little bit. And today, they have outsourced, basically what they do is they staff, deal with quality, and deal with billing in various parts of the hospitals. It probably doesn't make sense for academic medical centers, but it makes sense for a ton of hospitals that are smaller. And so they started in the emergency room. Then they bought, this is a hospitalist company, it's the biggest one. They bought that a couple years ago. They run anesthesia in hospital, inpatient services. They do a lot of provider-based services. 3,400 hospitals, 19,000 healthcare professionals, and they, arguably do a good job. But Lynn, ER doc, was in the ER and basically said to his hospital, I'm going to manage this thing and you're going to pay me a fee. And that's how he got into the business. Did it himself, took the risk, and put this company together. And today he is moving to some of these things we talked about. And frankly, strategically, again, it was a staffing company, put docs in various places in the hospital, but they strategically decided they had to get to value. So they now, because they're ER hospitalists, they believe that they can control the admissions, the discharges, and post-acute care. And my gut tells me they can. It really hasn't been proven out yet, but that's where they're going. Managing the post-acute management. And when the hospitals contract with these guys, again, they're saying, well, can you get the right patients in the hospital? Can you discharge them in a timely fashion? And can you make sure they go to the best quality, most cost-effective post-acute place? So they're moving the needle. Again, dollars. Nobody's interested in this stuff but me, but this is kind of interesting, right? So here's 99 when they started. Here is revenue. And so they went from a hundreds of $1 million company. Today in 2016, these guys were just taken private. So they were a public company called Team Health. A group called Blackstone took them private for $6 billion. In my world, that's a lot of dough. And their revenues have increased dramatically. We're going to get more into some other case studies. There's not a great lesson here. My point in bringing up Team Health is that this guy did it. A physician, ER doc, started in 99, built a $6 billion company, is moving to value today, and that was one model. So here's the next model, Healthcare Partners. Anybody heard of them? Healthcare Partners, 1, 2. They're a pretty interesting group. So this guy's name is Bob Margolis, oncologist, was the head of a multi-specialty group, 40, 50 guys. And so he basically transformed this multi-specialty group. It was like Polyclinic. And they were down in Southern California, and he just started taking on risk. They really focused on primary care, away from the specialists. Today, they're owned by DaVita. They have a whole bunch of patients. They sold it for a bunch of money, $4.4 billion. But the key to what Bob did was risk-taking. He took advantage of the Medicare Advantage population. I'm not saying he took advantage of those patients personally, but basically, they did an incredible job of coordinating care. And it was all provider-based. So they had their own hospitalists, they had their own primary care folks, they had their own specialists, and they kept folks out of the hospital like nobody's business. 40% lower bed days on a Medicare patient than their competition in Southern California. And I talked to Bob, his secret sauce was I make it easier for docs. So he put social workers and various coordinators in the clinic so that you wouldn't send the patient to the ER. I mean, again, this isn't necessarily rocket science. I think your gut is that that's a really good idea. And but he did it. He did it himself. He took that risk on, and he built an organization that had lower cost, better quality, created a lot of equity value, enterprise value. But he is a physician, entrepreneur, leader, and literally this guy did it himself over a relatively short period of time, 20 years, which is relatively short. This is the one company that I am invested in. This is not me. This is David Joukowsky. This is an interesting story too. Let's see, do I have time? I got a little bit of time. So Joukowsky was head of recon at Mayo Clinic 10 years ago. Really young guy, I think he's 40-odd years old. And he decided there's got to be a better way. So he's Mayo Clinic, academic, like a bunch of guys sitting out there in the room. And he literally said, I'm going to do this a better way. He hired a consultant. They looked at payer data, Medicare data, population data. He would have moved anywhere in the country. And 3 guys, based on his data of where the population was and where he could make his mark, they all moved to Phoenix. They'd never been to Phoenix. They don't even like Phoenix. They moved to Phoenix. And they're literally out of their garage. And this is 2005. This is 11 years ago. Out of their garage, they start this orthopedics group, 3 guys. And I'll show you some data here. So today, they have 15 practices, 11 in Arizona, 4 in Michigan. We were in Louisiana, but that didn't go real well. And we have a hospital. We have ambulatory surgery centers. And we have 65 surgeons. I mean, it's a giant dominating practice in Phoenix, and it's pretty big in Detroit, and we're growing rapidly. 155 total providers. This guy did this in 11 years by himself. And he did it on the backs of data. I mean, he spent an absolute fortune on his IT systems. And I'll show you, protocols, pathways, care coordinators. Today, the business has a bunch of segments. They manage doctors, which is not a fun job, not particularly profitable. They work with Banner and co-manage the line inside the Banner hospital. So all the orthopedics goes through these guys. So the doctors and the nurses that are working for CORE, and the hospitalists, by the way, are sort of subcontracted to the hospital to care for musculoskeletal care. We own a hospital. It's pretty small, with like 45 beds, but we're able to very efficiently do orthopedic procedures there. We do almost all outpatient total recon. It's very inexpensive and it's super high quality. And then this year we started a PHO, a population health organization. So we get per member per month dollars to do all musculoskeletal care on patients in the Banner network. It's a pretty big business. We're taking risk on the upside and downside. This guy did this in 11 years. So, these are, I'll go through these really quickly, but just tons of IT and tons of reporting. These are utilization data. These are service line reports. Orthopedic volumes by day, productivity. This is case management. These are coming out daily, showing where patients are going, discharge to SNF, discharge to home, et cetera. This is by provider, which providers are sending patients to nursing homes, et cetera. Are the patients going to their education sessions? These reports are coming out daily on handhelds. And again, this guy did this himself. They do a ton of surgeon-to-surgeon stuff. And this is actually pretty interesting. This is focused provider practice evaluation. For most, and surgeons are a little bit different than the rest of us, but, clinical privileging is generally like, have you killed anybody, right? I mean, have you been reported? These guys get 360 reviews, all the doctors, at 60 and 120 days, and then once a year from everybody in their world. Scrub nurses, front desk people. So if you are just a monster surgeon, you can't work in this practice. And you get these reports and they get coached up. I mean, again, if you're a guy that's throwing stuff around the OR, you're going to get canned. And so they really manage their workforce. Anyway, lots of reports here. This is, I don't have really good data, but this is they have a preoperative scoring tool. So patient comes in for a total hip, they put in age, they put in a bunch of demographics, and it predicts whether or not they can go home or not. And social workers come in and think about it. You know, okay, can they go home? Why can't they go home? Can we manage that? Because I'm going to get into this, but they manage all the care and take risk on all their reconstructive procedures. And so if they can predict that someone's going to go to a SNF, a nursing home, they ask if they can do anything about that. And they'll literally fly in a family member, do something to keep them at home with home health if that's helpful. Okay, so quickly some results. This is a busy slide, but this is one of our facilities. And the take home, and these are other facilities for 481, which I think is a hip, and the difference between a core managed facility and non-core managed facility in Phoenix is almost $5,500. This is one hospital where they saved $500,000 in this one single hip replacement. This is readmissions. These are core facilities versus non-facilities. And so this is a core facility where readmit rates, and this is 90 days, let's just concentrate on that, are substantially lower than the system or the region with some big cost savings. This is use of post-acute. So this is SNF, which is nursing home use, and this is over time, 2012, 2016. Substantial use. This is home with outpatient physical therapy. That's going up. Length of stay is going down. Complications are going down. You know, this isn't an advertisement for this group. I really just bring it up because I think it's really interesting that this physician-led organization just willed this to happen. And I'm convinced, I mean, we're investors in the company, but, you know, they're doing this on a daily basis. And if this was not, and this is really physician-led, the three guys that run this are all docs. One's not operating, two still are operating. And they just convince their doctors and other staff members, they will it to work. And I think they're doing a really nice job. Pop Health, they are doing Pop Health at CORE. And again, we take per member per month. You know, this is Ambulatory Surgery Center. This is our hospital, and this is a Banner hospital. Okay, so this is a pretty interesting little one. So this is a joint replacement DRG 470. You know, what they do is they pay their docs a lot more per case. But if we can manage where the care is, so this is in a Banner hospital that's unmanaged. A 470 joint is coming in at $58,000. If we can do it as an outpatient ASC, it's half the price. And there's very good data that you can do safety. It clearly is you got to pick the right patient, you got to manage it carefully. But the way we do it is we pay the docs more to manage the care in here or in our hospital, where it's substantially cheaper than either of the other two hospitals in the Phoenix area. I think it's pretty interesting. Here's spine surgery. We also take risk on spine surgery. This is not going to be miraculous to you guys. If you do a spine surgery, you know, in this particular DRG, it's $37,000. If you take them only to the physical therapist, obviously it's much cheaper. We have protocols where everybody with back pain sees PT first. They don't see doctors. They don't get imaging. You know, there's some pushes and shoves here. There's giant amounts of savings. The doctors lose income, and we have to solve for that, right? We got to incent spine surgeons not to do spine surgery. That's not the world's easiest thing to do. But look at the savings here. And this is just in our Phoenix market. We project that we can save $18 million on a $2 million lost income for surgeons. So we've solved for that in other ways. I bring this up, again, just because there's tremendous opportunity in this one. Now, again, I think it's easier in orthopedics. You know, these are episodes of care. They're generally healthier patients. But I am inspired by this particular example. So we're really rounding the bend here, and I'm going to leave plenty of time for questions and discussions because I'm sure I didn't get this right. This is all ramblings in my own head, which is frightening. So the last decade of healthcare delivery innovation, to me, has slowed but not cured the problem. We've done a decent job in low-hanging fruit. Bundles, ACOs, integrated delivery have had modest but positive effect. I believe providers hold the key to unlocking value. And I think, again, if any of you in this room or friends or colleagues, I really think we need to train dozens of physicians to take this on. It's kind of interesting. I have a friend who's has a leadership position at Virginia Mason, and his ability to recruit junior docs to sort of help on the administrative side, they have no interest, which I thought was kind of interesting. They want to practice and go home. And I think there's a group of us that are interested in this stuff, and we got to figure out how to foster that and innovate it. I also would say another closing remark, and this is my last slide, you got to start somewhere. So, you can take on that quality team or, a utilization team, or you can become the manager, the physician manager of the CCU. But I think we got to think bigger, faster. And frankly, I think, the sort of academic, I'm going to be the head of this committee, and then I'm going to be head of the Harborview CCU, and then someday I'm going to be the medical director at Harborview, to me is going to be slow for what we need to do. So some of us have to raise our hands and sort of take on a bigger job. I don't fully understand how to get that trained up and how to do it quickly, but I think it's really imperative. I think it'd be really interesting if University of Washington took on something. We have obviously our MBA school, we have our public health school, we have, Steve, our health administration, MHA school. I don't know, from a distance, it doesn't seem that we're exactly curing this, but nobody in the country really is. I think Penn Wharton, is doing a decent job. I think Duke's doing a decent job. I think we can be better, and if people have bright ideas about how to get the next group moving faster, trained up, it'd be great. So I'm going to stop there and open it up for any questions or discussions.
Hi, Nathan. Welcome back. One area that you didn't specifically address that lots of economists have talked about is just our prices for everything are high compared to many other places in the world. And total joints is a great example where, there's 1,000 to 10,000 fold difference in the cost of the actual prosthetic device that we pay versus what another country might pay. Is it possible to do what you're talking about without some, intervention on the prices, not only for drugs and technology, but perhaps also for, as you say, with some of the bundles? Can we do this in a purely entrepreneurial way, or does there need to be the heavy hand of regulation involved?
My gut is, I think there's almost no chance that the heavy, I think there's no chance that with the political will to get regulation on pricing in the absence of a sweep away, if it's Bernie Sanders in a Democratic House and Senate. And that's obviously not going to happen in the near term. So I'm really skeptical about government intervention on pricing. At CORE in Phoenix, we use a single joint from a single company that we do competitive bidding, and it's 35% less than anybody else can get. Still probably decently more expensive in France and Germany, but that's incredible. And then site of service, we're doing an ASC, it's $25,000 versus $9,000. Same thing on post-acute. What we'll do is we'll say, who wants all our patients? How much per day? And every SNF bids on it. And so we evaluate them for quality and cost. So I think competition is going to move the needle if you get that giant market share. Is Providence doing it up here? I don't know why it's slower with these big organizations. They should have the clout to do it. I think UW probably doesn't. We're too small. But I'm skeptical on price control as being practical.
I have a couple of questions. It was very, very interesting, particularly about the core group. One always wonders in settings like that whether this group has somehow selected a healthier group of patients to take care of rather than other organizations, and that has perhaps contributed to their success. And the second question is, how do you integrate this model into a university that also has missions of research and teaching?
Man, on the second one, I honestly don't know. Let's go on the first one, though. At CORE, we have a giant, as it turns out, we have a giant Medicaid population down there. You know, for us, we're so big, there's a sort of an indirect assumption, meaning that we would rather take care of a very poorly reimbursed in Arizona Medicaid patient than not have that patient at all. I don't have great, you know, evidence that it's not selection, and I'm sure selection is involved in it, but I will tell you that we are 18% Medicaid payments at CORE. So I think we're doing a decent job. That may answer a little bit on the mission side. You know, we have another practice in another state and another specialty. On the mission side, we do all our Medicaid for free. And it's about 8% of the practice. It's not even worth it for us to bill. And the docs do it as part of service. Academically, there's no great answer. I think, again, we are subsidized. You know, the feds pay residents. I think we're all getting squeezed. I haven't been around here long enough to know, but we're getting squeezed on this cost thing. So I guess the only thought I have is that the business units, to the extent that they're autonomous, education is paid for in an education model, research is paid for in a research model, and care, I think we can be entrepreneurial. I think we're kind of going that way, right? We're doing the Boeing experiment, et cetera. I don't think those are subsidizing the other towers. That may be a bad thing, but I think that's probably the way we're going inevitably anyway. Yeah.
Also, thanks for those examples that you gave of success stories. So if you describe sort of some of this secret sauce, right, physician leadership, really good data, probably to some degree the right scope and size to do care coordination and better management. I'm also curious how you feel like this ties into the broader health system. So if the answer is clearly not one doc doing it on their own, and Kaisers on the other end of the spectrum have not really bent the cost curve, as you say, you know, and our group health is sort of going the way of Kaiser, right? They've said that their scale and scope is too small, so they're now Kaiser. How do you get from these slightly more limited integrated services where, again, maybe the orthopedics is lower hanging fruit? Primary care really is in some ways too, right? We can all imagine how reducing hospitalizations for ambulatory sensitive conditions with better care management is achievable. How do you get from that to a more sort of fully integrated health system? You know, do you just need better physician leadership and better data in Kaiser, or is there something about the scope and size that makes it more sensible to do this in more bite-sized chunks or something else?
I'm really skeptical of giant bureaucracies solving these things. Kaiser has it right in their hands to solve it. I mean, nobody's in a better position to solve this than Kaiser. And they're doing some things that are great. But their will to really force change is modest, right? You know, look, I'm going to get on the soapbox here, but they have all these highly, highly paid administrative folks that sit in committee meetings, and they don't own it. They don't push for big change, whereas the entrepreneurial thing, you know, I'm making payroll, you know, there's things that affect their daily life. So personally, again, I'm sure I'm going to get this wrong. A Providence or a Kaiser, I don't see that being the answer. Now, let's take the flip side. Can you take, and Healthcare Partners did it and failed at this. Can you take Healthcare Partners? It worked in Southern California. They spread it out to Arizona, Florida, Nevada. It was kind of a disaster. Not even kind of. And by the way, DaVita bought them. It's been kind of a disaster. And I think it's the same darn thing. I think the leadership and the focus goes in the big organizations, or when Healthcare Partners leaves Southern California, they don't manage well in the other markets. So in my world, which is small, we deal in single billions, not tens of billions. I really think our view is we're going to get CORE right in Phoenix, and we're going to spread it in Arizona. We are in Michigan. We'll spread it in Michigan. But we are not going to move out until we have the leadership and the IT systems to do it right. And by the way, the physician buy-in. The other one is top-down, do it my way. You just have to have the physician buy-in. So I'm not optimistic. I think your point's a very good one. But I like bottoms-up entrepreneurial versus top-down. I just don't see top-down working at the moment at all. Who's in charge of the questions here?
Okay. Oh, yes. In the remaining minute, what about administrative overhead? The Wool Handler Himmelstein model that, in fact, about 25% of hospital costs are administrative overhead. There are more employees in IT and administration than there are nurses and physicians, and we exceed other countries by far. Obviously, they've got the single payer model, but what's your response to that kind of critique, and how do we lower administrative overhead?
I think it's the last thing you said. Many of these things are around the payment system, right? We've got giant revenue cycle management folks, billing, rebilling, and that goes to IT. But I will say this, just to be bombastic or whatever the word is, hospital organizations, let's take University of Washington out, they're just not well run. And that's why I really think that we got to get the hospitals, these bricks and mortar, it's inefficient, right? We've got all these things that we do in these hospitals. So I like provider-based, contract out on the hospital on a daily basis. And believe me, when they compete, their administrative overhead's going to go down. They just haven't been forced to at all, I don't think. And, you know, the Medicaid boom and the new, Obamacare allowed them to continue to be fat over the last decade. But in Phoenix, in our orthopedics, we are bidding out hospital days on hips. And those prices are definitively, they're coming down. We're seeing them come down. So then the hospital's going to have to react. And, I think somebody just had a giant layoff. Providence Swedish had a giant layoff. That's in response to that. Lower census, lower payments. I think it's going to come down. It won't come down substantially until we get our payment system better. I think we're out of time, yeah?
Yeah, thank you very much, Dr. Everett.